Hello everyone, welcome to your 2012-2013 recertification pre-course process. I'm going to be talking to you a little bit about endotracheal intubation, and this is going to be followed up by a video which includes Dr. Mike Lewell, our Regional Medical Director, Pete Morassutti, our Regional Paramedic Educator, as well as myself, Dwayne Cottel, Regional Paramedic Educator. What are our objectives today? At the end of this, the paramedic should be able to summarize the indications, the conditions, and the contraindications for the use of endotracheal intubation, and be able to demonstrate the ability to correctly apply the directive in a variety of different clinical settings. So endotracheal intubation, many challenges surround this. So although it's a relatively straightforward technique to teach, the greater challenge is when the paramedic should intubate using sound clinical judgment. So when should we do it? When should we not do it? Okay, so a few things are involved in that are the position of our patient or ourselves. Okay, the majority of the people that we come across that need to be intubated are in not the most appropriate positions. They're not supine on the table with good lighting. Okay, the majority of these patients are in cardiac arrest, and when these patients just drop, okay, they don't fall into a nice supine position and everything's just perfect. Okay, some are trapped in vehicles. Those patients actually require face-to-face intubations. Others may be trapped upside down or underneath in combines and all kinds of stuff, just different scenarios. So it requires us to be able to adapt quickly and get into different positions in order to maintain the patient's area, taking into account our safety as well. Lighting conditions, these can be troublesome as well. When you are performing endotracheal intubation, they sometimes, if it's too bright out, it may cast a shadowing inside the oral cavity and result of inability to see the cords and all the other associated structures. Over-aggressive, overzealous intubation attempts can result in oral cavity trauma, cord lacerations, tongue lacerations, hard and soft palate injuries, broken teeth. So we have to be very cognizant when we go to intubate gently regardless of the situation, and just take our time and do it right the first time without causing any harm to the patient. ET tube decisions that need to be made on scene or en route to the ER. So timing of our intubation. If an airway is effectively controlled by less aggressive means than using an endotracheal tube, then we should be staying with that. Only time we're going to intubate is when failure of all other methods and we need to secure the airway or inability to manage the airway with a patient. Taking into account people with head, neck, or spinal injuries. Remember, last thing we want to do is hyperextend the neck or hyperflex the neck. We want to keep a neutral inline alignment there and stabilizing with collar and intubating, being cognizant, intubating very gently. So what are our indications to intubate a patient? So we need ventilatory assistance or airway control, and other airway management is deemed inadequate or ineffective. Whether it's an oral airway, a King LT, it's just not working, the airway's filling full of blood, vomitus, that sort of thing, and you need to secure that airway, then we go on to tubing our patient. So some of our contraindications for intubating a patient, the one is if they're less than 50 years of age and they're in asthma exacerbation and they're not in cardiac arrest yet or near cardiac arrest, we don't want to be tubing these patients. They're still breathing, they're having air exchange, we just want to kind of leave it alone for right now. Specific to nasotracheal intubation, so people with uncontrolled epistaxis, bleeding disorders, if they're on anticoagulants, that's excluding ASA, and if they have a basal skull fracture or a midline facial fracture, one of the Lafort's type fractures, we want to stay away from nasally intubating these people. Last thing we want is any more bleeding complications or any more trauma associated with that, or increasing intracranial pressure spikes as a result of nasally intubating these people. So what's our required equipment? So we'll need our laryngoscope with the blade properly selected, make sure it's lit. We'll have our endotracheal tube, our stylet, our syringe, a securing device, the appropriate lubricant for the tube itself, BVM hooked up to oxygen. You're going to have a suction apparatus of some sort there. McGill forceps in case we need to remove any type of foreign bodies, your cardiac monitoring equipment, oral and nasal airways, and your gloves, your face shield, your goggles, that sort of thing, and then your confirmation devices, whether that be end-tidal CO2 by waveform on your cardiac monitor, or end-tidal CO2 by colorimetric system, or esophageal detector device. Those are our secondary type method confirmation tools. Assessing difficult airways or difficulties for intubation, many different acronyms out there. One is bones, so beard, obese, no teeth, the elderly, or people with snoring respirations. Okay, these can all pose problems. The 4Ds, so the dentition, distortion, disproportion, or dysmobility in the jaw itself. And then we also look at the MALS acronym, so mandibles itself, the opening of the oral cavity, the position of the uvula itself, the teeth, the head itself, any trauma located, any silhouettes, any shadowing being cast into the oral cavity. And now you're going to see a video of Dr. Lewell, Pete Morassutti, and myself showing you different little tips and tricks. Thanks.
Good morning and welcome to the Southwest Ontario Regional Base Hospital Program training video on intubation. With me today, I'm Mike Lewell, I'm the Regional Medical Director, and I'm here with
Pete Morassutti, Regional Paramedic Instructor.
And Dwayne Cottel, Regional Paramedic Educator.
We're going to talk about the process for intubation here. We're actually going to demonstrate the skill here a couple times with different sort of problem shooting techniques we've learned. First of all, before we decide to intubate someone, perhaps Pete, if you're actually bagging this patient as if this patient was to be intubated, we need to layer out our material and see our equipment and see what we need to have ready to actually process the intubation. So, Dwayne, what kind of things do you need to have ready before you secure a tube?
We'll have our suction readily available. We'll have our laryngoscope with the blade selected and light appropriately working. We'll have our proper sized endotracheal tube with our syringe attached. Stylet is optional. We'll have the lubricant for the tube. We will have a securing device to secure the tube into place. We'll have our stethoscope for confirmation purposes. We'll also have either a colorimetric end-tidal detector or waveform detector, as well as esophageal detector device.
Great. Okay. So in this situation, we have we mentioned tube sizes. So for a standard adult, we're looking at 8 to 8.5. That's male, and for a standard female, we're looking at 7 to 7.5. And in a pediatric case, we're looking at the formula of 4 plus the age over 4 to be able to give you the actual size of the tube. You can also use the size of the child's pinky finger or the small finger to be able to tell you the tube size as well. Other techniques to be able to figure out tube size?
The size of the right nair is a good way to.
Great. So now we have the intubation set up. We have all the equipment we require. Pete's bagging the patient. Dwayne, do you want to walk through the process of actually intubating this patient, and we'll narrate as we move?
Absolutely. Okay, so my partner is oxygenating the patient. And then when I'm ready to intubate, once my equipment is prepped, always checking the cuff on your endotracheal tube to make sure there's good integrity. And all my equipment is laid out and readily available for what I need. And oxygenating the patient just to build up their stores. And when I'm ready to intubate, I would ask Pete to remove the bag and the oral airway. Okay, I am ready now.
So as Dwayne's doing this, he's actually moving the patient into a more of an extended position of the neck called a sniffing position and slowly introducing the laryngoscope. One of the keys is that many times people just drop the laryngoscope in violently and pull up hoping to see the cords, but if you move in a stepwise progression, you can actually course along the back of the tongue and actually identify the epiglottis and then position the end of the laryngoscope, the tip, actually in the vallecula to actually see the epiglottis lift, therefore identifying actually where the glottic opening is. Can you see where you need to go?
Absolutely.
If you notice Dwayne's technique now, he's not levering back on the laryngoscope, he's actually maintaining the laryngoscope, pushing forward, and the actual handle of the blade moves up towards the wall and towards the ceiling, so you're moving in a forward direction away from the upper teeth, therefore minimizing the dental trauma you have with intubation. You maintain your eyes on the glottic opening and you ask for your tube from your assistant there if you have that hand, which is a luxury we have today. We don't always have that luxury. And atraumatically we introduce the stylet. Great, and you want the stylet out?
Please.
Great, we'll pull that out. And now the issue becomes tube confirmation. So how do we confirm that that tube is in?
So maintaining where the tube is at, what I'm going to be doing is looking for chest rise and fall. My partner's confirming. Can you please ventilate the patient? Looking for chest rise and fall. When I have that, we do a 5-point auscultation. First over the epigastrum to assure there's no air entry there. Then over the left base, then the right base, then the left apice, and then the right apice. And once that's confirmed, that's our primary confirmation. At this point, I can take my esophageal detector device, if that is what your service is utilizing, place here, aspirate for free air, and there is free air at that point. From
And that
here,
tells you that the tube is in the trachea?
it is in the trachea.
If the
now.
tube is in the esophagus, what happens?
The esophageal detector device, it will not pull out. It's just dead, it stops.
So it basically suction with the esophagus and basically collapses thus so you cannot move up. So therefore
Correct.
it's most likely in the trachea but fully free falls out.
Correct.
Great, okay. Other methods of confirmation?
Other method is a colorimetric type of system. It's a quantitative. Different devices are available. The ones, you pull the tab from this point, you can hook up onto your tube, the bag goes back on. The colorimetric, depending on the particular device, it would display an end-tidal carbon dioxide of greater to or equal 5%. It would turn the litmus paper in there yellow.
Okay.
With this particular device. If it turns green, it's saying, well, you might want to, tan or green, might want to think about where you're at just
Right.
for confirmation. Or if it's blue or purple, that means you are in the stomach. There's no carbon dioxide being produced at all.
One of the false positives of this is that you may have actually the tube in the trachea, but you actually don't have any end-tidal CO2 because the person's been arrested for some time because they're actually not generating the physiologic exhaust, which is end-tidal CO2. Therefore, you may not necessarily 100% get colorimetric change, but you should develop some colorimetric change and that there's some residual CO2 left in the bronchus tree. Well done, okay. Now, any other methods we have here? Because we see this device here.
Yep.
We have the capnography system,
Okay.
which comes on the LifePak 15 and the Zols, I believe. If you turn on your monitor and you can hook up your capnography between the tube and the BBM,
Great.
you should be able to get a reading. As soon as you attach, you'll scroll over and bring up is end-tidal CO2, and it'll auto scale, and you can change to see if you get a waveform.
So if you're getting waveform with end-tidal CO2, by definition, you have to have the tube in place. And remember that in the arrested patient, yet again, although with good CPR, we should get some end-tidal CO2 return because we're having good circulation, but we may not always necessarily 100% have it. Soft measures of knowing the tube is in place are things like misting at the tube and also, as you described, listening. And remember that the natural tendency when you see the glottic opening is to insert the tube so far that you wind up down the right main stem. So you ought to be cautious about having to move the tube back. Let's talk about patient positioning. Let's remove this tube and let's talk about patient positioning. There may be two other sort of techniques we can use that we've learned some of the skills that where it becomes difficult and then some problem-shooting methods we have. So one of the more common things is you have you want to put the patient in the best sniffing position, but there is some evidence to showing that if you put them in too much an extended position, what can actually happen is you actually put pressure on the glottic opening and compress the area. Therefore, there's some techniques we can use to be able to tell us that we're going to make this a bit easier. One is using the earlobe here, the base of the earlobe to the suprasternal notch. So if you position these in a linear fashion like this, so by using some head rolls or towels that you may have. And the other thing is that if we look from a horizontal point of view, that the head should actually be horizontal with the ceiling. So now we have the head horizontal and the ear to the suprasternal notch. Let's try an intubation attempt with this. Yet again, it's always calm and controlled, and you're inserting, so therefore you should always be able to tell where that tip of the laryngoscope blade is, so people can ask you, what are you seeing, if you see epiglottis, or if you see cords, where you're at. Remember, not again levering back, and I must say, these guys have big forearms and good strong arms. I don't have that same advantage, therefore I need every mechanical advantage like I have here, being able to get the patient in the optimum position, and that way it helps you to be able to mechanically lever that glottic opening up. Good. How'd you find that, Dwayne?
Good. It worked well.
If you notice Dwayne's hand when he's holding the laryngoscope blade, he holds it down here. This accomplishes two things. It also prevents him from actually putting the laryngoscope blade too deep in the actual glottic opening, which therefore sometimes obscures your view of the cords. You're actually in the esophagus. So if you insert it, for instance, on this side, you're automatically cutting down the length of your blade, and you know actually dexterity-wise where the teeth are, where the lips are, and it prevents you from going in too deeply. A second sort of technique that I've learned recently is that when you insert the laryngoscope, you may notice that if you're having a hard time, you can actually move the lips to the side here by pulling or having an assistant pull to the side. That may actually allow you to see the cords a bit easier. And also the third thing would be to actually bring the trachea as well as the cricoid to you, and that's called the burp method, back upwards and to the right. So if you do that, it may bring the glottic opening into the view a bit better. You can actually have someone else say, hold that right there, and then you can pass the tube as well. The third unique situation that we want to talk about is the morbidly obese patient. In this situation, there's a thing called the ramp technique. And the ramp technique is, you may notice that when people are fully arrested and laying down like this, their chest, if they're morbidly obese, tends to fall up, and so does their neck, and it actually may collapse and obscure their airway. So yet again, maintaining the same principle of a horizontal face and then the earlobe in connection on the same line as the suprasternal notch, we can actually maintain that by ramping the entire body up like this. So that may be on your stretcher, actually lifting the stretcher up to be able to maintain that same position, or it may be as simple as trying to prop them up with pillows or a whole bunch of towels, whatever you have at the house, or even if you're intubating them on their couch, or whatever you're doing in the home. But yet maintaining that same principle, so horizontal face, earlobe next to the sternal notch, and Pete, do you want to give that an intubation? Try and see if they felt that. When I'm doing this with one of my residents and medical students, I always have this nervous thing where I actually grab their lip and make sure we don't pinch that between the teeth as well. But you guys don't have that luxury. It's so much easier for us in emerge when we have like 10 people around helping us with this intubation. How do you find that?
Very nice.
Good. So that's the ramp technique, and it can be used for morbidly obese patients. So to summarize, preparation with all our equipment out, if we have that time available, get everything you need. Make sure the passage of the tube goes smoothly. Take your time, identify the anatomy, and then afterwards confirm the tube is in the right position. And think of these keys with regard to patient positioning, which may enable you to increase your success of actually successfully intubating the patient. That's all we have. Thanks very much.